Good morning, Professor Paul Froom here. I want to talk to you today about an elevated white count. This patient was a 55-year-old or is a 55-year-old male who has a WBC white count that is over the normal of 12,000. Here he has 34,000, 33.9 thousand cells. The physician ordered, because of a test done 3 days ago, a repeat CBC, complete blood count, along with a request for a smear, to look at the smear, and also a LAPA, leucoallyl alkaline phosphatase, which is a test that used to be done in the old days to rule out chronic myeloid leukemia. The test even then was not reliable, and today there are tests, that genetic tests, that can help you make the diagnosis of chronic myelogenous leukemia. However, just looking at the blood count, where you have 76% lymphocytes and not an increase in neutrophils or immature neutrophils, we're talking not about CML, and the physician should have been thinking about chronic lymphatic leukemia, CLL. Now, in chronic lymphatic leukemia, it's important to see if the patient is anemic, or thrombopenic. Here you can see that his hemoglobin and number of red blood cells are within normal limits. The hemoglobin should be over 12 to 13 grams per deciliter, and here you can see it's normal. Also, with the ADVIA analyzer, you get the proportion of cells that are big, macrocytes, microcytes, small, too much hemoglobin per cell, hyperchromic, and too little hemoglobin per cell, hypochromic. Here we can see that all these percentages are less than 5%, which means that they are within normal limits. The platelet count was also normal. So we're talking here about a patient who has an increased has lymphocytosis, increased lymphocytes, and the suspected diagnosis should be chronic lymphatic leukemia. Now, how do you make that diagnosis? Chronic lymphatic leukemia is made by sending cells for flow cytometry, which can tell you if the cells are the same type. And if they are the same type, this makes the diagnosis of CLL. Now, we didn't have flow cytometry many years ago, and we used instead a definition that meant if you had an increased lymphocyte count over 5,000 for more than 6 months, that made your diagnosis. You could also make the diagnosis acutely if you found that the patient had lymphadenopathy, lymph nodes that are enlarged in various places in the body. Well, let's see what he had a few years ago. Nearly 5 years ago, he had a completely normal blood count, and there was not an increase in the absolute number of lymphocytes, although the proportion was high. If you take 50% of around 8,000, you get around 4,000 lymphocytes. Somewhere between 2008, December 2008, and April 2010, he had an increase in lymphocytes, and he passed the threshold of 5,000 cells. So here at this time, it should have been suspected that the patient has chronic lymphatic leukemia, and 6 months later, the blood test could have been repeated. Not that it's really important, because the patient remained asymptomatic until even now, 2.5 years later, when finally the white count, you could see, is much higher. So here is when the disease started, between here and here, And you can see that the physician sent numerous other tests. The reason that he sent the tests is unclear. Ferritin, he had sent, here's 2 levels of ferritin, one that is low, one that is borderline, and he had sent 2 levels of vitamin D12 and folic acid, and it's really unclear why and not indicated to send these tests in somebody without anemia and who was asymptomatic. Certainly, even if you suspected iron deficiency, you wouldn't start a gastrointestinal workup in somebody who didn't have anemia with a ferritin that was low. You also, at this period, you also sent again ferritin, iron, C-reactive protein, thyroid stimulating hormone, vitamin B12, and folic acid, tests that are not indicated. So let's summarize this patient. We started out with an increased white count, leukocytosis. We narrowed it down to lymphocytosis. The suspected diagnosis was CLL. We look to make sure that there's not anemia or thrombopenia, since anemia is common in these patients because of an increased risk of having antibodies to your red cells, and the possibility that you get a crowding out effect in the bone marrow where the white cells don't interfere with normal erythropoiesis and thrombopoiesis. The physician should have examined the patient to see if he has increased nodes, lymph nodes, increased size in his lymph nodes. And then if he doesn't, this can be defined as a very early stage of CLL, and there is no need to do anything except follow up the patient.